I don't see it on Facebook. Is the video supposed to show on Facebook?
Welcome to Alpha. Welcome to Alpha. Welcome to Alpha. Welcome to Alpha. Welcome to Alpha.
Welcome back. Can you all hear me? Hello?
Sounds good. Sounds good.
Yeah,
Okay, let's start. All right.
very clear.
All right, first slide, please. Back. Well, welcome back to the First Baptist Church Community Connection, where for the past few weeks, we have been exploring exhaustively the topic which has been at the top of our minds for the last 1.5 years, which is the COVID-19 pandemic. And as we are speaking to each other now, we're all under EMCO, which is the worst of the worst. I hope everybody is fine. We've exhaustively covered in the past 2 episodes vaccinations, testing for COVID-19, home and GP management of the disease, blood clots for AstraZeneca specifically, myocarditis for Pfizer, COVID in children. Today, we're going to do a deep dive into the hospital management of what happens if you're sick enough, God forbid, to warrant hospitalization or even to get into the dreaded ICU. So to look at this, we actually have people who are very experienced in this area. We have respiratory physician, Dr. Chua Ken Tiong, who looks after you in the ward, as well as ICU, and ICU specialist, Dr. Suresh Venugopal, who is an anesthetist who basically looks after patients who are intubated in ICU. On the flip side, we have 2 patients, and on one end is Mr. Vincent Yee, who was recently admitted to Sungai Buloh but didn't get quite as far as the ICU. And then we've got our sister Corinne Au, who was admitted to Subang Medical Center and went to ICU, I believe, twice, receiving assistance in her respiration and ICU. So we will also have a time for a lot of questions. So please remember to drop your questions via the chat room, Facebook, or YouTube Live. Now, before we begin, there's a next slide, please. There's a little bit of a disclaimer. All the opinions expressed during this session are solely that of the presenters and not of First Baptist Church. Right, so let's get on with the first topic. Now, the first topic is basically the most critical. If you happen to wind up in ICU, you will meet this gentleman, my good friend and colleague, Dr. Suresh Venugopal, who is a specialist in anesthesiology, who I work with every single week, who's a wonderful and expert anesthetist, who will now run you through his aspect of how you actually manage COVID-19 when you wind up in ICU. Over to you, Dr. Suresh.
Okay, can you hear me?
Yep, fine.
All right. Let me introduce myself. My name is Suresh, and I'm an anesthetist and also intensive care doctor. Anesthetists in this country are trained to do intensive care. It's just the way we are, but there are separations of the role. But in private sector, by far, anesthetists manage the intensive care, both ventilated and patients who require oxygen. So COVID-19 has been causing quite a number of problems for the last 1.5 years. And ever since that, I've been in Subang. And of course, our numbers are not as high as those in the government, but we do have a fair amount of experience managing those patients. So I'm just going, can I have the next slide, please? A little bit of myself. I finished my anesthetic training in 2006, and I've been working as an anesthetist for the last 15 years. I'm just going to break down the talk into some brief introduction to COVID and vaccines, which I think Chua will talk more. Some clinical manifestations of the COVID, mainly critical care management of the patients, and what do we expect are the problems in intensive care and the challenges. Can I have the next slide? So this was an infection which originated in Wuhan in December 2019, became a global health emergency the next month, and became a global pandemic in March 11th, 2020. It's known as the SARS coronavirus 2, which is similar to the initial SARS outbreak in 2002, which is nothing like, and this outbreak is far, far worse. Can I have the next slide, please? So worldwide, until last week, there were a total of 181 million infections, out of which Malaysia has about 700 and I can't see mine. Okay, 81 million infections in Malaysia is about 72,000, I think, 800 numbers. Worldwide, there's close to 4 million deaths, while we have gone up to 484,000, nearly 5,000 deaths. The problem is, while most numbers are plateauing, we are finding a surge in number of deaths. We are having between 50 to 100 deaths a day, and our peak deaths was in 2nd of June, where we had 126 deaths. Now, this is a tremendous number and a tremendous strain in our healthcare system. Next, please. So we look at the graph and how the chart is. So they will have peaks and wanes, and the current problem now we are going through another peak period. Next. A bit about the variants, which seem to be causing quite a bit of the resurgence. There's the alpha, beta, gamma, epsilon, and delta variant. What we are very afraid of now is the delta variant, which seems to be much, much more infectious, and has been, in some instances, immune to the vaccination. Doesn't seem to render you totally ineffective to the COVID disease. Now, most of the vaccine protects us very well. Even if we do get an infection, we don't seem to end up in critical care, which is the main aim of the vaccination. Next one, please. Next slide, please. So at the current progress, in Malaysia, 1.97 million individuals have been vaccinated for 2 doses, which is just about 6%. We aim to achieve 80% vaccination by September, and the numbers of PPVs and the number of vaccination is actually growing quite well, and I hope that we can achieve this 80% by September, which will really release the stress from our healthcare system. Next, please. Okay, so a bit of this COVID virus, how does it present? Next. So it comes through spreads through respiratory droplets. It attaches to the nasal, which is actually somewhere near your nose, nasal and oral mucosa, where through the spike protein, it attaches to this particular receptor. It goes into the cells and then it gets transported and it multiplies, and it causes a host of causes host damage by affecting actually multi-organ disorder. It does affect every organ, but primarily the lung, because the lung is the one which is vital, that gives us oxygen. So, but it's just not the lung that is damaged by this disease. It also affects the coagulation system, the heart system, the kidney system. So what we essentially see is a very varied presentation, although the most important thing is the oxygen delivery, which is poor. That means we have less oxygen given to the tissue and we get hypoxia, which is actually low oxygen tension in the blood. Next, please. So let's assume that you contract the virus at day 0, and majority of the presentation is usually within 4 to 8 days. So the incubation period can be anytime before that. And most patients or most people will have constitutional symptoms like nausea, headache, sore throat, cough, fever. Varying reports on varying percentages of symptoms, including loss of smell and all that. Usually your PCR test will be positive at the day 3 or day 4. And usually by day 15, you're considered immune, you're considered over the infective period. And that's why our quarantine period is for 14 days. Next, please. So in Malaysia and worldwide, we categorize them from grade 1 to grade 5 clinical stages. Now, clinical stage 1 and 2 are generally not admitted. We used to admit some of the category 1s when there were a lot of beds in hospital, primarily for quarantine purposes when they didn't have, when they had to share homes with family members, but not anymore. Most asymptomatic patients and symptomatic patients of category 2 are kept at home unless you are at high risk of progression to severe disease, wherein then you will be admitted to a government facility where they will monitor you. You may not need any treatment, but you will be monitored. From grade 3 onwards, then you get admitted to hospital. You could be symptomatic with pneumonia, symptomatic with oxygen requirements, or critically ill. Now, 80% of patients do not have any symptoms. They are either category 1 and 2. Now, the problem lies when you are category 3 and above, and we have no idea who progresses to category 3, although there are certain risk factors for certain people. For example, obesity, diabetes, hypertension, chronic disease, cancers. These are groups of patients, and of course, age. When you're older than 65, these are the groups of patients that do progress to grade 3 onwards. Next, please. Now, you can have lots of symptoms like fever, dyspnea, which I've mentioned earlier, cough, lethargy, and clinical examination is important, where you may or may not see breathlessness. Breathlessness is defined as when your respiratory rate is more than 20. Most of them will have subtle breathlessness, although they do not feel too tired. Now, the key is checking the pulse oximeter. If your saturation at room air sea level is 95% or below, it does mean that you have lung involvement already. And then there will be a host of blood tests that you will do when the patient is admitted to see how ill you are. And these are all within the domains of the physician. Now, when you are severe, you would generally have a respiratory rate of 30 and above, and an oxygen tension in the pulse oximeter of less than 90% on room air at sea level. So these are danger signs that you would need admission immediately. Next. So these are the risk factors for those patients who are probably at risk for progressing to grade 3, 4 and above. Unfortunately, nowadays, we are seeing more and more patients who do not even have any risk factors who are progressing to grade 3 and 4. This is unexplainable unless it's the variants which are circulating in this country which are causing problems. Next, please. So the complications of COVID are varied. So as I said, you will have lung damage where they can cause pneumonia, ARDS-like. ARDS is an acute respiratory distress syndrome, which I'll explain a bit more later. What happens is that you get lung damage throughout, and when this lung damage happens, there's just less chance of you to transfer oxygen from the air to the blood. And you may have other complications relating to the lung, which is like pulmonary embolism, which means blood clots, which is very peculiar to this disease, where you can get blood clots not only in the blood, but also in the lungs and in the arteries of the lungs, which are life-threatening. Cardiac events, like you can have a heart attack or heart failure. Thromboembolism, which is actually blood clots happening in the deep vein system, which is also life-threatening. And of course, multi-order systems like sepsis, which is actually profound infection causing blood pressure drops, kidney injury, and liver injury. So this disease does just not affect the lung, it affects every part of the organ. Next, please. So how do we triage patients coming to intensive care, or how do we decide a patient needs to come to intensive care? Next, please. So before that, the physician would actually manage the patients in the ward. Now, most patients there would be either in the first few days of the illness. If they require oxygen therapy, if you look at how the incubation period in day 5, then the oxygen levels can come down, requiring you to be symptomatic and treatment. So in the first 7 days, you usually require just antiviral treatments. After the 7th day, where the inflammatory disease kicks in, then you may need not only antivirals, because the antivirals generally don't work after the first week. You may need steroids and anticoagulants. Now, these are much more important, especially when you need oxygen. And let's assume that your oxygen delivery is more than a certain amount, and then the physician will make a call to the intensive care and say, hey, my patient is getting sick, he needs an intensive care bed. And then that's when the patients come up to us. So we got a few phases of this disease. Generally, by far, we see most of them at the early pulmonary phase and late pulmonary phase. They don't seem to come to us in the early stages because it's generally manageable. Most of them, when they come to us, they're already on steroids and requiring a lot of oxygen. Next, please. So how do we assess which patient needs to come up? So we assess the amount of hypoxia. Hypoxia just means low oxygen tension in the blood. So we check the amount of oxygen through a pulse oximetry. As I said earlier, patients don't get admitted unless their saturation is less than 95%. So they are now in the ward requiring a bit of oxygen. Now, if you're requiring 6 liters a minute or less, you're safe to be kept in the ward. Anything more than 6 liters would mean you need more vigilance, and that's when you're transferred to intensive care. Now, in intensive care, we do a series of assessment, looking at your respiratory rate, looking at how much oxygen you need, and we calculate a thing called the PF ratio, which is actually the amount of oxygen in the blood as opposed to amount of being delivered to you. And if the PF ratio is less than 300, it would mean there's significant lung damage. Next, please. So what happens in this lung, for example, if you look at where the normal lung tissue is, where that's where the oxygen comes in through the normal, and the oxygen diffuses through the blood system. The things with the red dots are all blood cells, and they pick up oxygen. Now, if you look at on the other side where the thing mentioned low VQ, these are damaged lungs. So these damaged lungs, the oxygen doesn't seem to travel across these damaged lungs into the blood, and therefore blood cannot pick up this oxygen, and that's how we get hypoxia. Next, please. So, and this disease is a bit peculiar. Most patients who have hypoxia from a normal pneumonia, you would be breathless. But this disease is called a happy hypoxia. That means sometimes they don't know, they wouldn't know that they are very ill, because when we check the oxygen levels in them, it could be below 90%, but they feel normal. So that's why oxygen monitoring at home for certain patients is quite important, because we do not know which patients will turn bad very fast. And sometimes the deterioration is quite rapid. Next, please. Okay, now we are looking at a chest x-ray of a patient who was in intensive care, and these changes happened within 3 days. Now we look at the left side. This is a person whose the black tissue is considered lung. It's not perfect, but neither is it bad, because the oxygen saturation is manageable. Now, if you look at the right side, you look whitish appearance happening quite rapidly, and this is diffuse alveolar and lung damage by this COVID infection. And these kind of patients, the ventilator will be working, giving extra oxygen, maximum oxygen generally, and high pressures to make sure there's enough oxygen delivery to the blood. Next, please. So now we come to the intensive care. So patients are brought in by a stretcher, and it's called a special stretcher where there's a filters mechanism from the ward to the intensive care. Then in intensive care, the patient is assessed. What do we do with them? Do we just continue normal oxygen, or do we go a step up? So in Subang here, we have one dedicated ICU where we've helped the government set up 8 beds for the government. I think we are one of the bigger private hospitals who have allocated quite a number of 10% of our ICU. We have about 30 beds, and we've given them nearly 10 beds of intensive care beds. So we've sacrificed 1/3 of our ICU beds for this disease, and we're trying to help the government as much as possible. Then we have also one ward with 24 beds just for COVID-19 patients. Now, so when the patient comes up, we are doing an assessment. Both the physician and the anesthetic doctor will do an assessment, and then we will decide. What we look at is the clinical condition of the patient. Are they breathless or not? How much of oxygen is being delivered? How much of oxygen is being generated in the blood? And are they breathless? Are they hypotensive? Are they requiring kidney support? Are they restless? Because are they worried? Are they scared? So most patients are very terrified when they can come to intensive care. They are extremely anxious, because you see patients, you see staff all gowned with the PPEs, and it is actually quite terrifying when you come in with COVID, because coming from the ward, then you come in intensive care. It's a surreal feeling. You feel like, is this going to be it? Am I going to survive this? So, but rest assured, we are very, we try to comfort you as much as possible and give you what you need. So supplemental oxygen starts off from nasal prongs, which we normally do. And then if you don't have the normal oxygen delivery which you can do in the ward with the face mask, and that doesn't work, then we go to a thing called high flow nasal cannula or ventilation. So I'm going to talk next, please. So this is more for the doctors. Can we go to the next one, please? Okay, this is a high flow nasal cannula. Now, this is proposed to be the next step up when we fail when we fail to get oxygen with the normal oxygen mask. Now, this is a device which gives us humidified, warm oxygen at at a set concentration and at a high flow. And this is attached to a flow meter and then to a humidifier and goes attached to your nose. It's actually very comfortable, and patients generally tolerate this quite well. So we can give up to 100% oxygen and a flow of 0 to 60 liters a minute. This improves oxygenation by various reasons. It does improve amount of oxygen given to us. And as long as our oxygen saturation is more than 90% and we are not very breathless, we continue this therapy. Next, please. So it is heated. It can meet the patient's demands because when they are breathless, with this high flow of oxygen, you feel better. With the high flow, it increases the functional residual capacity, which is actually something where we try to give some pressure to the lungs so that the lungs open up and can function better. It is quite a light system and it is easy on the patients, and we can calculate the amount of oxygen we give very accurately. Next, please. This is example of how AVO looks like. A high flow nasal cannula, one of the brands is called AVO, which we have quite a number in Subang. It is connected there and it's connected to this gentleman who is through the nasal tubes, and he looks quite comfortable and happy with it. Next, please. So, and this has been shown by both CDC and the respiratory societies throughout the world to be the first line above normal oxygen delivery. The other option was using a thing called BiPAP, which is normally used in patients with, for example, obstructive sleep apnea in the community. You may have seen some of your friends having this thing called a BiPAP, which you use it at night to sleep because you have obstructive sleep apnea. Now, that's the other device that we can use for patients before mechanical ventilation. But of course, the theory is that it may propagate the virus more and infect more healthcare staff. So the first step is using this high flow nasal cannula or AVO. Next, please. Now, should we fail to get oxygen levels improved with AVO and BiPAPs, then we have to do the inevitable. We have to put you to sleep, put you on a ventilator, and this is how 2 healthcare workers are doing it. If you see carefully, there's a ventilator behind the healthcare worker. There's a person wearing a device which is hooked on. If you see the person on the left, there's this black colored tubing, and that's called a PAPR, a purified air respirator. This is so that the healthcare worker does not get infected by the COVID virus. Now you look at the person who's directly opposite the patient, and they are trying to put an endotracheal tube into the trachea to give oxygen, and they are using a video scope so that their face is not too close to the airway of the patient, because the virus can, of course, spread very easily with aerosol procedures. Now, this procedure is usually done in the intensive care, and it's done very carefully because we cannot afford to infect ourselves, and of course we cannot afford to let the patient desaturate too fast. Most of the patients that require mechanical ventilation, there are about 5 to 10% of patients who eventually require mechanical ventilation like this. Next, please. So when you are mechanically ventilated, all is not lost. We have been shown to improve some patients. Of course, some do pass away. But what happens is that most of them who require this machine are having severe ARDS, means severe lung damage. Now, something that has been useful for them is turning them around. That means lying face down. Lying face down for 12 to 16 hours has been shown to improve oxygenation. Now, certain patients, we just can't possibly do that because we need manpower to do that. And a lot of hospitals in our country are being stretched to the limit. We just don't have enough critical care nurses. We don't have enough nurses who are trained in critical care to do this kind of procedures. And that's what you may have a physical area to do all this, but we don't have the manpower in our country. This is a challenge our country has never seen before. So we've never experienced such a pandemic of which requires intensive care support this much. So turning them around, putting them prone, face down for 16 hours a day has been shown to improve outcome for these patients. Next, please. So to do a prone, can you imagine, these are the number of staff that you require. You need 6 to 7 people to turn a person facing down so that nothing gets dislodged, none of the lines get dislodged. This is a huge manpower challenge. Huge manpower challenge. In each intensive care, for example, in Subang, we have 8 patients. Can you imagine proning 5 of them and then turning them back? We need a lot of staff strength to do this. And that's why it's not easy to just open up ICU beds. It's just not the physical beds, it's the staffing and experienced staff at that too. Next, please. And these are the challenges that we face in intensive care. As we know, obesity is one of those high risk factors for severe deterioration of COVID. They are very big. They are very difficult to give oxygen because they're very difficult to ventilate because the chest wall is so thick and the pressures. Some of these patients don't make it because they have lung damage, irreversible lung damage like pneumothorax, which is damage to the lung, and some of them do pass away. Next, please. This is another step of how you're doing prone, and you just look at the sheer number of staff that is required to turn a person back facing down. Next, please. This is an example of a person who's already facing down. Look at the tube which is passing on the right side of the patient and the ECG leads. We protect the eyes and they're lying on soft, usually pillow, and we do check the patients regularly for any pressure on any of the limbs and the chest. Next, please. So, next, please. Okay, then comes the next step. Sometimes these patients have problems with the lung, where the lung gets blocked and there's just poor oxygen delivery. And you see this gentleman here doing what we call a fiber optic bronchoscopy. And this is to clear certain segments of the lung from phlegm. It also is used for diagnostic for certain patients who are COVID positive, but who seem to be have the clinical criteria of COVID positive, but their nasal swabs are negative. So this test, which we do to get samples from the lower bronchus or the lower parts of the lung, has been shown to be better in terms of yield for the COVID PCR test. Next, please. But what we know for sure is this disease is very steroid responsive, and steroids are normally started, next please, at usually when they start to require oxygen. When they have pneumonia and require oxygen, now they start. And the most commonly used steroid, it depends on the institution you go and the physician they use. It's either dexamethasone, which is a cheap and available steroids, or methylprednisolone. Both are equally efficacious, although Dexa has been shown to be improving the outcome better in the big trials. Now, these are available drugs in this hospital and in all Malaysian hospitals, and this has been shown to reduce the lung damage and have shown to improve outcomes for patients, especially after day 7 of the COVID virus. Next, please. Next, please. And this is just about the dose of the steroid, which is not so important for us, but already shows that they just give us a guideline on how much of steroids to use in the next few days. Next, please. Next, please. Okay, so what happens is in the first 7 days, they get this viremia and you started them on these antiviral treatments, and then they get worse. So what happens is that there's widespread fibrosing or inflammation. The inflammation portion of it is causing lung damage, and that's why steroids are being used. And usually Dr. Chua will be able to explain more about how he titrates the steroids, because steroids prolonged use of steroids is also associated with other issues like immunosuppression. That means you can get other infections because of opportunistic infection. You can also get other issues from prolonged steroid use like skin thinning, blood disorders, and other stuff. Next, please. Okay, this slide was taken from Sungai Buloh in the early stages. In December, late December, the mortality has been about 14%. Generally, our outcome until the recent surge, our mortality has been below 2%. I am not sure what has happened in the last few months where the numbers have surged and our mortality rate or death rate has increased tremendously. So our numbers are definitely not 2% anymore. The risk of death is much, much higher. As I've told you earlier, 80% don't come to ICU, 15% get admitted to the ward, and 5% get admitted to ICU. Out of that 5%, 2% generally die. But when we have a surge in numbers, some patients who require intensive care cannot come in because there are no beds. For every 4 patients with COVID, 1 would require an ICU bed. So if we have 10,000, 20,000, 30,000 infections, then we are in trouble. Active infections, that is. Next, please. Can we go on? Next, please. Okay, so how do we cope with the surge? So we are talking about not only the physical place. As we speak today, Hospital Kuala Lumpur, Hospital Serdang, Hospital Sungai Buloh are all full. I have colleagues there who are struggling every day because there's just not enough beds. So we have staff problems because the staff have to take breaks and they are wearing the PPEs the whole day, so it's quite tiring. At the moment, there are no supply problems, but some conflicting reports coming that they may have some oxygen problems, but I'm not privy to that knowledge. But as far as I'm concerned, in Subang, we still have enough supplies. Space problems in the government because they've opened up all the critical care units to COVID, and they've also opened up wards. That means they're putting patients in the wards and ventilating them. And in theater, in the operating theater, they're using the operating theater to manage these patients. So essentially, they've stopped all planned operations and they're only doing emergency operations to cope with this surge. Next, please. So oxygen shortage has been reported overseas, and we really hope that this doesn't happen in our country. But if there is a big surge, let me assure you that, the government will be doing all it can to provide enough oxygen. But the problem with this disease is this disease takes a long time per person to recover. So I hope we never come to this stage. Next, please. Next, please. Next, please. Okay. So what are the challenges that we face in the ICU? Okay. Traditionally, we've been having intensive care is such that we need a quite close nursing to patient ratio. Every nurse takes care of 1 patient or 2 patients at the most. If they are light and easy, then the nurse may take 2 patients. That means they don't need mechanical ventilations. But most of the COVID patients are considered difficult to manage, so they need 1-to-1 nursing. We do not have the nursing power in the government to provide this kind of nursing. So what happens, they take nurses from elsewhere who are not critical care trained to help this ICU nurses cope. So maybe an ICU nurse would be a mentor and she'll have 3 or 4 nurses to supervise all these patients. So we have inadequate doctors now because most of the intensive care has been managed by anesthesia in the intensive care pool, and we have a finite number. So we have to use other doctors who are from surgical backgrounds and from physician backgrounds to come and help us in intensive care. We may have been hearing about the new contract doctors. A lot of them have been put into this front line to take care of the COVID patients. And they are quite junior, and they have to be. They have tried their best to improve. Of course, it's a big ask for some of the junior doctors to step up into the role that they've been asked for. So organization, because of the rapid sudden surge in numbers and the ICU requirements has actually put our faults to bear. So we know now what we need to be done. Next, please. So ICU staff exhaustion is a real thing. It is extremely tiring to take care of an intensive care patient wearing a full PPE for 12 hours. Let me tell you, I've seen some staff cry when they go home. And some of them have to actually work 2 shifts. That means they have to work a 16-hour to 20-hour shifts before they go home. And there's no option to say no. We just have to do it. Next, please. So staff well-being is always on top of our mind. It's just that the number of patients are so sick that most staff actually hide their emotions. They are physically and mentally fatigued. I know some of them are depressed because there's just no time off. There's just no time to just recollect and just switch off. They are always fearful of picking up an infection. And if they do pick up an infection, how about their family members? Morale has been up. Most of them, they consider this as national service. So, it's for our own people, it's for our own Malaysians. So we don't complain about the work. But of course, fear is always there. Next, please. Now, access to intensive care is the biggest problem that we are having now. There are at the moment 950 patients who are in intensive care, and out of that, mainly about 450 are ventilated. Now, throughout the country, I think if you just look at intensive care beds, there are about 700 odd beds available, and that means that we've opened up wards to intensive care, and also some field hospitals, especially in Labuan and Johor Bahru, some in KL, to provide intensive care beds. Next, please. So the long hours in PPE are a big thing. PPE supply used to be a problem in the early days, but not anymore. Now, when we are donned in all this thick equipment, sometimes doing procedures can be very difficult and sometimes risky, but there's just no option. Infection control measures sometimes take a backseat because it's just impossible, because to do a proper infection control to prevent infection from happening, you need better staffing and better space, which is sometimes impossible. Resuscitation is another issue that happens because some of them require CPR to do. If let's say a patient collapses in the intensive care, the staff have to re-don everything and go in and help other staff, and our resuscitation isn't sometimes as good as when there was no COVID. And some of these patients require emergency operations. Thank God there are not that many, but if let's say a cesarean patient who's we need a cesarean or a debridement for a wound, then we have special theaters designed for these COVID patients. They're not available in all hospitals, but what essentially we need is negative pressure theaters where we can protect the people outside the theater from getting infected. Next, please. Now, then this is what I feel is the biggest challenge. Family visitations are not allowed. Now, before a patient is sometimes put on a ventilator, it's actually quite sad. We do communicate with the family just before a patient is put on a ventilator, and sometimes they are not. The family will have a direct chat with the patient through the phone, and we can see the crying happening. It is extremely distressing for the medical staff to see that happening, especially if we feel that the outcome is not going to be good. Sometimes patients don't make it. We are very happy when some of them make it and get better and leave, go out of ICU, but 30 to 40% of them who are ventilated sometimes pass away. And there's a small subgroup of patients who are just do not improve and who require high amount of oxygen for, let's say, 2 to 3 weeks. And sometimes discussions are held with family members whether it is in the interest of the patient not to continue doing if we feel there's no chance of improvement, especially if the patient is of an advanced age and has been not well even before the COVID. Sometimes then we do what a discussion on end of life, which means that we may withdraw support just to be humane to the patient so that they don't end up suffering too long on the ventilator. Next, please. So that's called palliative care, and palliative care is a big thing in intensive care, where we sometimes let patients pass on in a dignified manner. We provide support to the family and the patient, and so that patient does not suffer throughout the procedure. Next, please. A few questions. A lot of patients ask us, or friends ask us, would you need a COVID test before coming for an operation? Yes, the answer is yes. Would a COVID vaccine interfere with anesthesia? Absolutely no. Some suggest that the Pfizer vaccine does cause some inflammation in the first week, so sometimes some of the surgeons here just don't do surgery immediately after a COVID vaccination. Is it safe to have surgery if you recently contracted a COVID-19? That's yes and no. If you have just been discharged from hospital from COVID-19, usually the standard teaching is that you don't have surgery for 1 to 3 months, depending how severe you were. If you had been very severe, we try and delay it for 3 months. Obviously, if you had cancer or some urgent surgery, we bypass all that rules. Should you wait until you're fully vaccinated by having surgery? It depends on the surgery. If it is urgent, you need it done, then you should do it. Next, please. And I think that's it. Thank you.
Well, thank you very much, Dr. Suresh, for that excellent presentation. It really brings us into ICU, and we can see the dedicated staff that have been actually putting their lives on the line and serving. I just have a lot of questions coming up and some comments. I had a comment from Peter Chu, who said he just recovered from COVID-19 after 23 days, with 9 days in the ICU. Just to ask Suresh before we ask the next doctor to come on, it's just that if you're on vent flow, the nasal oxygen, what is your survival rate going to be like? I know it's, if you're on the ventilator, it's bad. About 40% don't make, who die.
Well,
but what about if you're on this high flow?
Well, the mortality generally has been less than 2%. But
if you're on vent flow,
when you it could range from between 2% to 20%, depending whether you progress onto a ventilation. Mechanical ventilation per se has been shown to have a higher mortality, and that's just based on the disease being such a huge burden on yourself. It could be up to 40% on a mechanical ventilator, and something below that on a high flow. In our hospital, we've had patients who successfully been managed by vent flows and been discharged. However, our results with mechanical ventilation has been average. Which is the national average, which is about 40% to 50% death.
Okay, good. All right, so we need to move on. Time is catching up with us. So I'd like to introduce our next speaker, Dr. Chua Ken Tiong, who is a respiratory physician, has graduated from the University of Dundee, Scotland, member of the Royal College of Physicians and a consultant at the University Hospital before joining us. He's a specialist in pulmonary fibrosis as well, which is what happens to you if you've got COVID in the ward. So he's going to answer all your questions as well, especially on this issue of ivermectin, which everybody's already putting questions to us. All right, so Dr. Chua, over to you, sir.
All right. Okay, good afternoon, everyone. All right, thanks for having me here, and good to have everyone here. Okay, so today my objective today is just to share a bit of my case management experience. About my experience of managing a COVID patient. Ever since the Ministry of Health endorsed private centers, private hospitals to look after COVID patients, unfortunately, we have taken quite a fair share of in SGMC. So along the way, I've been labeled the COVID physician, right? Not a title I'm proud of, right? So, but it's just something that we have to do lah. So I think basically my presentation can be divided into 3 parts. Okay, the first part is only 1 slide. I would like to explain to you about the natural cause of the COVID-19 infection. The second part is I'm going to share with you, I think about 7 cases of what I managed over the past few months, right? So just to let you have a feel of what's going on in the hospital. The third part is a vaccination, right? So now the first part has only got 1 slide, okay? So Dr. Suresh has shared this slide already, okay? So this slide, just let me take you through it. The x-axis, right, actually denote the time, okay, the time. So as a patient progress from here to this way, so as the time go on, day 5, day 10, eventually either recover or they die. The y-axis denote the disease severity, right? So let's just focus on stage 1. Okay, at the beginning, okay, so with this is what we call a
Can we share screen, Dr. Chua?
Oh, I have I not?
Can't see. We cannot see your screen.
Oh,
Can we share the previous slide?
I have. So sorry. Let me just try to do that. Share screen.
Yeah. Fred.
Hold on.
Or Sweatway. Who's got the slide? Ah, good. Sweatway. Okay, good.
No. Hold on, So this your slide, is it? So no. I mean, I would like to use back my Hold on.
Okay.
Let me do this.
You share your screen.
Okay, right, there you go.
Okay, good. All right, good.
Right. So the first phase of the disease, all right, is actually what we call a viremic phase. Okay, it's early infection. This is a time when the virus replicates itself. All right, from 1 become 2, 2 become 4. At this stage, either people have no symptoms, so they are still in a carrier phase, or they start to have mild to moderate symptoms. The common symptoms will be like fever, cough, runny nose, sore throat, loss of taste, loss of smell, fatigue, body ache. Right, so at this time we can already detect the disease by using the PCR test. Right, so usually this phase usually lasts around 5 days, about 5 to 7 days, right? So after this phase, either patient recovered or they move on to the second phase. In the second phase, right, the virus continue to replicate, all right? So again, I stress not everyone move into this phase, okay? But for those who does, all right, so the virus continue to replicate itself and start to attack the lungs, okay? So that's when people start to get pneumonia, right? So then this is the time that people start to feel breathless, especially when they exert themselves when they do things, right? And from a medical point of view, when we do X-ray, or when we do CT scan, we will see the typical X-ray or CT scan changes, which is quite different from the normal pneumonia, the normal lung infection that we see. Right, at this stage, then definitely in the hospital will be more aggressive. This is the phase where treatment we start to give treatment. Now with treatment, okay, some people the disease regresses, okay, so the people start to recover, so that's great. But again, for small percentage of patient, right, then they move on to stage 3, what we call the hyperinflammatory phase. Now this is basically the dangerous phase of the COVID. All right, very few patients okay move into this phase, right, about 5% as per Dr. Suresh the data. Right, when patients move into this phase, this is when okay the body runs into big trouble. There's a excessive inflammation going on inside the body. Number 1, it happens in the lung, so the pneumonia get worse and progresses into a condition called ARDS, which is a severe lung damage. Right, so people at this stage also develop sepsis, so meaning that this infection. Respiratory failure when their lungs cannot support anymore, doesn't function properly anymore. And it's also people develop cytokine storm. That's when low blood pressure occurs, kidney injury occurs, the digestive system might fail, right? So this is a hyperinflammatory phase of the COVID infection. And this is the most tricky part of the management of COVID patient. Right, so this is a natural progression of it. So again, I stress most people stay within phase 1, the stage 1, the viremic phase, and recover. Right, so but some may progress, and the more they progress, and the more severe the disease is. Dr. Suresh had mentioned briefly about this table. Now, this clinical staging, we divide patient into 5 stages. right? So those are the criteria of how we stage them. The first stage, or what some people call them category 1. The first category, category 1 is basically the COVID test is positive, but the person got no symptom. The second stage or second category is that they start to have symptom like fever, but there's no pneumonia, there's no lung involvement. The third stage is when they have fever, symptom, and also there's evidence of lung infection or lung involvement by the COVID. Stage 4 is when patients start to need oxygen on top of what they had already. And stage 5 is when a multi-organ involvement. That means that the whole body, almost the whole body got involved, got attacked by the COVID, right? So these 5 stages. So these 5 stages is important for us as a treating clinician, because right, it actually determine the treatment that we give to the patient, and also it gives us a rough idea of how they give us a bit of idea how they prognosticate the patient. Basically, how they will fare, whether they will do well, they won't do well. Basically, but the higher the stage is, then the poorer the patient does. Right. So the next part of my presentation, okay, involve case sharing. Right. So just a small number of cases I treated along the way. Right. Case 1, okay, is it can be any age, and it can be age. These are patient, you know, they've been in close contact with some infected person. They went for the screening test, which turned out to be positive. Right. Of course, if the person is young, healthy, they stay at home. So they say they do home quarantine. But for some people, because of certain criteria like age, like if they are not so healthy, has diabetes or poor immune system, then they're advised to do hospital quarantine. So when we take in these people into the hospital, then what we do is we just monitor their vital signs every 4 hours. So basically, we measure their blood pressure, temperature, pulse. Every day we have to do a 1-minute sit-stand test. Basically, it's a type of exercise test. We want to stress the patient and see how well they can cope, how well their lungs can cope with the exercise. That will predict the lung involvement in COVID. And then usually we do blood tests every 2-3 days in the hospital. And of course, at this stage, at this type of patient, they do not need treatment because they've got no symptoms, stage 1. So these are patients, if they got no symptoms, they remain well, then they can discharge after 10 days of quarantine from the test date, right? So this is stage 1 COVID infection. This is the type of the patient that I feel happy for them, because they've gone through the infection without having any problems at all. I mean, and without any health problems at all. Well, obviously, quarantine itself is a huge bother for a lot of people. Case 2, okay, so again, it can be of any age, okay, younger age tend to be younger age. They start to have symptoms like fever, cough, sore throat. So they go for a test, they are tested positive, and some of them may choose to be hospitalized for whatever reason, maybe of their worry, maybe of their body condition, right? So this type of patient, if their X-ray is normal, so then that's great. So typically, this type of patient, the fever subsides after about 5 days or so. But still, we have to monitor them, keep them in the hospital, all right, so for 10 days. So if they remain well, then they can be discharged after 10 days. So these are patients, because they have symptoms, they have fever, they have symptoms, so they are stage 2 infection. So again, not too bad, usually quite straightforward cases, they can be discharged quite well. Now, and the next type of patient is going to be more severe, right? These are patients tend to be older, but can be young. Like recently, I think about 2 weeks ago, I took this man in, right? So he had fever, cough, sore throat. I think the whole family was tested positive for COVID. So when he came in, he was fine. He had a bit of breathlessness, but it's not too bad. So he came in on the day 6 of his illness. Now, if you can see, we always label like, oh, what's the day, you know, this day 6 of illness, this thing here. Now, this day 6 of illness, now this is very important, right? Because again, for us is that we use this duration, how many days of their illness, to roughly know what stage they are in and whether they are moving into the next phase of the COVID infection or not. right? So as he comes in, we tested him positive, right? So already at that time, day 6, there was a bit of lung changes. Basically, there was already a bit of a COVID lung evidence of COVID pneumonia. So at the time, I give him this favipiravir. Now this is an antiviral. So usually we give it for the patient from stage 3 onwards. Okay, some in stage 2, but mostly stage 3 and onwards, they'll need this favipiravir. This medication helps to try to kill the virus, to keep it short. It's COVID virus killer. Right. So, but unfortunately, this man, he did not improve. He on the day 9, he's still having fever. You know, he came in on day 6. On day 9, he still had fever. Now he still had some breathlessness, but still not too bad. He didn't require oxygen. He could still walk to the toilet and back. But the thing is, the blood test got worse. Right. Remember I say while they're in the hospital, we have to do regular blood tests to monitor them. So at that time, I wasn't too happy. Right. So I say, okay, fine, let's move on to do a CT scan then. Oh my goodness, the CT scan actually showed a much worse appearance compared to the X-ray. There were quite a fair bit of COVID lung. Okay, so at the time I had to give him some steroid. Right, so again, as Dr. Suresh mentioned earlier on, COVID disease, right, is largely a steroid responsive disease. Right, for a lot of people, luckily, when we give steroid, they do respond, they do improve after that. So it's a case for this man. Okay, after the steroid goes in, then the fever subsided, the fever settled down, his breathing difficulty improved, and the blood markers start to drop. Right, so that's how, because of his illness, it's more severe as a stage 3 disease. So he actually had to stay longer a bit for the good recovery of his health condition, and that's why he was let go. He was discharged from my care on the 14th day of the illness. So the final diagnosis was stage 3. Subsequently, he came back for follow-up 1 week later. He was doing well after that. Right. So this again a good case where they respond to treatment. So end up with a happy patient. Happy patient means happy doctor. Now there will be another. The worst type of patient will be like this patient, right, who is under my care. Old man, 71 years old, diabetes, early dementia, has some symptom with fever, cough. The GP already diagnosed him with COVID. Right, so the family was actually initially trying to keep him at home, but because of his dementia, you know, he insists to go out and things like that. So the family couldn't cope, so had to bring him into SGMC. Now he came in on the 6th day of his illness. So at the time I say, okay, fine, still not too bad. Okay, so give him some favipiravir, again the antiviral to help him to kill the virus. So initially he was quite okay. I mean, for the first few days, I mean, he was able to eat. He doesn't need oxygen. He kept trying to get out of his bed. Okay, so we are quite worried of people like these old people. You know, they get out of bed, they can have a fall. But however, around the day 9, about 3 days after the admission, he started to deteriorate. Right, he started to need oxygen. The blood markers got worse. And when I did a CT scan, we show them, oh, there's a lot of COVID inflammation or COVID pneumonia on the scan. So at the time, I had to give him oxygen, and then I started him on steroid. Right, unfortunately, he didn't continue. He didn't improve, so he continued to worsen. So at the time, I have no choice but to bring him to ICU and call in Dr. Suresh to help me. So at the time, we give him this high flow oxygen cannula. Right, so the AVO that Dr. Suresh mentioned. So I have to switch him over to the higher grade of steroid. So basically give him more powerful steroid to try to control the COVID lung. It didn't work, right? So it didn't work. Then the next thing we give is this thing called tocilizumab. All right, tocilizumab is a very powerful anti-inflammatory medication. Remember, this man had already moved into stage, the phase 3 of his COVID illness is a hyper-inflammatory phase. So we give this tocilizumab, which costs about 5K per shot, right? So I give him about 2 shots, I think. So after that, he kind of stabilized a bit, and around the day 14, right, finally his disease stopped to progress. His oxygen requirement as well as the blood markers start to peak and stop. Right, so at the time he was unwell, got poor appetite. At the time, but luckily at the time around day 14, he started to reach the peak of his illness and he started to improve. All right, so but the improvement, we didn't see improvement until day 21. So day 21, okay, so he started to improve. His appetite improved, his conscious level improved, he's more kind of cooperative with us, and his oxygen requirements start to drop, right? So currently, okay, he's still in our ICU, right? So it's already day 27 of his illness. He's now only on low flow oxygen cannula, right, from the thick oxygen tube. He's now using a small oxygen tube. Okay, so and I hope that sometime next week, within the next 1 week, right, hopefully I can discharge him. So I think this man, luckily, eventually he responded to treatment, a lot of treatment, and we can look forward to the brighter tomorrow. So there's a patient of stage 4 COVID-19 infection. So typically, this type of patient will need more help from us, more treatment, okay, and but luckily some patient, most patient like this man improve with treatment. Case 5 is also a man under my care, still under my care, right? So 74-year-old man, known to have diabetes, high blood pressure. Again, he started off with some fever, cough, which is a very typical COVID symptoms. Tested positive. He came early on day 4. Right, so because of his age, his comorbidity, because he got diabetes, high blood pressure, I give him the favipiravir a little bit early to try to help him to kill the virus. Right, however, right, so again, his fever just seems to persist, and around day 8, about 4 days later, then he really become breathless. Right, X-ray was much worse, and the CT scan again showed very bad lungs. Okay, because of the COVID. Right, so at the time, of course, the blood markers worsened. We put it on oxygen. We put it on steroid. Right, so so at the time, hey, he seemed to stabilize. So he stayed in the ward. Right, so he was just hanging on, no improvement, but he stopped deteriorating. However, around the 12th day of illness, so he suddenly deteriorated. Right, so he suddenly become worse. The oxygen level dropped further. So at the time, we had to put him on a ventilator. Okay, so again, those rest had to wear his the gadget. Okay, so to put a tube down the throat to put the patient on the ventilator. Okay, so again, at the time, we tried very hard, give him more steroid, give him a higher dose of steroid, give him the tocilizumab. Okay, but since then, there's not much of improvement. So currently, he's already at day 50 of his illness. He's still on the ventilator. All right. So that's actually because when we do the further scan subsequently, right? I think the last scan was about 1-2 weeks ago. It just showed that the lungs are badly damaged by the infection, and it looks like it's going to be, the damage may look like it's irreparable. It may look like irreversible lung damage. Right, so along the way, like now he requires some blood pressure boosting medication. He has developed a severe infection. That's a result of too long in the ICU, too long on the ventilator, too much of or rather poor immune system because of all this treatment. And at the moment, he's still very septic, and the fever is still going on, and he just doesn't seem to be responding to our antibiotics. So this is this is an example of one of the very difficult COVID cases that we have to deal with along the way. Okay, patient end up with a very prolonged disease. The COVID is long gone. Okay, but we are dealing with the consequences of the COVID that's left behind in the body, especially the lung damage. Case 6 is a 92-year-old woman. Okay, she recently had a stroke, diabetes, high blood pressure, high cholesterol. So she was hospitalized with fever. Okay, now on the 6 days of the illness, she was confirmed to have COVID. At the time, that's when I was called in to help her, to give her treatment. So at the time, she was fine. She was alert. She was eating. She was talking to me fine, saying, okay, well, she looks to be fine. So let's give her some favipiravir, help her a little bit, get rid of the virus, and see how she goes. Unfortunately, a few days after that, she started to deteriorate. She became drowsy. She stopped eating. The oxygen level dropped. The blood pressure dropped. Okay, that's despite me giving her the steroid. So at the time, we had a discussion about it. So the family say, we probably don't want to be too heroic. Okay, let's be humane to her. So 2 days after the deterioration, then she passed away. So this is an example of very rapid progression. I think it's because of her age, of her body, of her health condition that's not so great. I think the virus, right, is more aggressive compared to other people. Right, so I do have, obviously along the way, I also have some patients like this, tend to be younger. Okay, they develop a stage 5 COVID infection. They stay in the ICU for a very long time. I end up giving them a lot of steroid, some antibiotic. And typically they are discharged, okay, after a very prolonged stay. Now, this kind of case, what I want to bring up is that, look, during follow-up, right, typically, they've got a lot of complaint. I mean, they have a lot of symptoms, post-COVID symptoms. Like this lady say cannot sleep, anxious. I know I won't blame her. You know, I mean, after surviving such an older, right, I'm sure I also cannot sleep very well myself. So she got muscle illness, muscle weakness, you know, up to a point that can't even stand up properly, right? So there's actually an effect of prolonged ICU stay, prolonged immobility, as in during the ICU stay she couldn't move, and so partly because of the steroid. You know, steroid eventually also one of the side effects is make the muscle weak, right? And she has some headache along the way, right? So we after one year, almost 2 years of dealing with this COVID, we have learned as well as a medical fraternity, is that, look, those patients who survive from COVID, especially the more severe COVID, once they recover, they don't just like that go back to normal. They don't really, right? So they tend to end up with problems, with long-term complication. Some of them get very generalized problem like fatigue, feeling tired, pain, fever, even sometimes even fever without infection. It's just fever, no infection. So obviously can have psychological or psychiatric problems like depression and anxiety. They can have ear, nose, and throat leftover effect like earache, sore throat, loss of taste, loss of smell. They can have stomach disturbance. They can have musculoskeletal weakness or pain. They can have neurological problem, basically nerve problem. Some of them end up with things like headache, with tingling sensation, and also dizziness, and things like that. Respiratory, so some of them end up with chronic cough afterwards because of the lung damage by the COVID. They end up with chronic cough, and they may still feel breathless when they do a lot of things. They cannot be just like their normal self before the COVID. Some of them have cardiovascular heart problem like chest pain, palpitation. Some of them has got some skin problem like skin rashes. So all these are the potential leftover effect after a COVID infection, especially COVID, especially the severe COVID. And my experience of seeing all these stage 4, stage 5 patients, when they come back to see me, yeah, typically they're like that. Typically they take a long time to recover. Right, so the next part is the last part. So I'm going to touch on COVID vaccine. All right, so so for subsequently for following slides, a lot of it, right? I take it out from this guideline. Right, these are clinical guidelines on COVID-19 vaccination in Malaysia, 2nd edition. I believe that if you go and search, right, you can find it on the internet. You can download for free, right? So maybe a bit difficult for you to understand because it's meant for doctors, right? But you can try to read because I find this guideline very useful, very pragmatic, very practical, right? So in the guideline, it tells us that, look, these are the vaccine, okay, that's been approved by the Malaysian Ministry of Health, right? So, but obviously the one that's ongoing is the first 3, the Pfizer, the AstraZeneca, and the Sinovac, right? So, just to bring your attention to this row here. So basically, the vaccine is largely quite effective to protect us from the infection. So, but most importantly is that these vaccines, no matter which one, actually helps to reduce the severity of the infection. Because no matter how good the vaccine is, it cannot be 100%. Okay, so for those who still contract the infection after the vaccine, it has been shown that the disease tends to be milder. and this vaccinated person, right, end up with less hospitalization, and definitely, right, much less people died from the COVID infection after their vaccine. Now, you ask me who should get COVID vaccine. Now, my personal experience, my personal feeling is almost anyone above the age of 18. Now, I know, of course, now we approved age 12 to 17 now. I know that. But I would say that anyone above the age of 18, almost everyone, right? The guidelines say, the guideline tells us there's a priority group. Okay, so this group of people, right, should get the vaccine even earlier. Right, so because this group of patients, they tend to have more severe disease when they contract the infection. For example, immunocompromised due to disease or treatment, right? So HIV patient, asplenia or dysfunction of spleen. So some people had their spleen removed because of accident or whatever reason. Those people with heart problem, kidney problem, liver problem, neurological disease is like nerve or brain condition. Respiratory disease is a lung problems, diabetes, obesity, or severe mental illnesses. So all these people should be prioritized and they should get their vaccine early. Next slide is that, okay, who should not get COVID-19 infection? Okay, basically the contraindication. Now, again, this table is from the guideline, is in the guideline. So the guideline tells us that, look, the vaccine is contraindicated. You can see the red color box there. It's only two conditions only. Only two conditions, only two types of people should not get vaccine. All right. So number one is those, right, with severe allergic reaction, okay, after a previous dose or to any ingredient of the COVID-19 vaccine. And number two is an allergic reaction of any severity within 72 hours after a previous dose or any known allergy to any ingredient of the COVID-19 infection, COVID-19 vaccine, sorry. Now, so you see, okay, so basically the guidelines is tell us this. Look, the only people, right, who shouldn't go for the vaccine is when you had one vaccine, you had the first dose and you develop problems, then you shouldn't go for a second dose, right? So this is what's listed in the guideline, right? So of course, I mean, of course, there are still a few that's not mentioned here, but these two are the most important. For example, I can tell you that someone with active illness, for example, someone who just had a stroke, someone who is having a lung infection currently, someone who just had a heart attack last week. Of course, all these people have acute illness; they shouldn't go for it. For example, pregnancy, during the first trimester and the third trimester, basically the first third of the pregnancy and the final third of the pregnancy, they shouldn't go for the vaccine, right? So, but very few of this group of example. Sorry. Right now, the second part, now the yellow box, okay, tells us, okay, fine, there's a special precaution, okay, for this group of people. Basically, the yellow group, right, the groups in the yellow box, right, tells us that these people can go for the vaccine, but we have to be careful, and ideally, right, the vaccine should be given in the hospital rather than the vaccine center, like the convention center, some stadium, so they should be sent to the hospital. So who are those? Now, those are with a known history of anaphylaxis. Anaphylaxis is severe allergy to previous vaccines. This one means other vaccine, like influenza vaccine, like pneumococcal vaccine, and other type of vaccine, right? Or number two, history of severe allergic reaction to medication that contain these polyethylene glycol and polysorbate. Right, so again, this is very specific type of ingredient, because the vaccine, the Pfizer and the AZ and the Sputnik vaccine that contain this kind of ingredient. The third one will be history of anaphylaxis to severe allergic reaction to a few type of medication. Number four is people with anaphylaxis, severe allergic reaction, but being idiopathic, as in don't know what they're allergic to, right? So it's called idiopathic anaphylaxis, right? These people can go for vaccine, but have to be careful, right? To be done in the hospital with a prolonged observation time. Or allergic towards any vaccine, right? So these are the group that they can still go for vaccine, but just be careful, longer time of observation, and to be done in the hospital. The green box is basically any other group, right? So this group, all the rest can go for vaccine quite safely. So even things like prior history of allergic reaction to food, to pet, to allergens, asthma, atopy, allergies, family history of allergies. So you name it lah. So you name it. So actually a lot. So basically, right? So some people have different type of allergy. For example, this chronic spontaneous urticaria. You know, some urticaria is the type of skin rash. There's a raised one. 風膜 the Cantonese say 風膜. So there's some people, they get this kind of skin rash. Even those can go for vaccine, right? So that's why a majority of the population above the age of 18, right, is deemed to be medically fit to get the vaccine. Then the next part of the guideline actually give us this kind of box. That's why these boxes, right, these tables, it gives us a scenario. It gives a scenario and say what to do about it. So that's why I say this guideline is so practical. So you see the first one, it says here, oh look, someone 50 years old man, okay, then with urticaria, the skin rash, the lip swelling, shortness of breath due to penicillin allergy. You can see the problem here is the patient had got anaphylaxis to penicillin, and the conclusion is they can still vaccinate, but they need longer observation. The second group is also a common type of allergy. Basically, it's an allergy to a type of medication called NSAIDs. NSAIDs is things like Brufen, Voltaren, Coxia. So this again something very common. Penicillin and NSAIDs allergy are very common allergy. So these are people also can get the vaccine, okay, but again longer observation. Now, so obviously, again, some cases it mentioned here, if there's a history of allergy to previous influenza vaccine, then we have to be selective in terms of which vaccine to give. So we can still give the COVID vaccine, but we have to choose for this type of people. Food allergy, alcohol or food allergy, no problem, can vaccinate. Now this SJS-TEN is Stevens-Johnson syndrome. Basically, it's a very scary skin allergic reaction. Okay, so you know the bad type of Stevens-Johnson syndrome, patient can go blind. Okay, but still in this type of patient, right, the guidelines say can vaccinate, no problem. Okay, again, just have to be careful to be done in the hospital. But obviously another scenario is that bronchial asthma, wheezing. Basically means that the asthma is unstable. Now when the medical condition is unstable, then the guidelines say, okay, fine, defer vaccination. Right, again, some other condition, again, when we worry that someone may be allergic to the ingredient of vaccine, then again, we have to be selective. We can give other type of vaccine that doesn't contain this polyethylene glycol or polysorbate. Now the next question, the next thing we are always very concerned is this thing, variants of concern, right? So I'm sure that all of you have heard of this with so much information in your social media. So basically we are identifying mutation, you know, as we are learning to help to fight this virus. We are learning what medication to use, when to use, how to use. The virus is also learning against us. So then when they learn against us, they start to mutate, they become stronger, and they become more contagious, right? So for example, the original virus, okay, the R0 is about 2.4 to 2.6. I think a lot of you probably have heard of this thing if you have been following Tan Sri or Hisham media kind of release. So basically, the higher the number, the higher the R0, the more contagious it is. But the alpha variant and the delta variant, okay, there's an India strain, is the R0 is much higher, 5 to 8. So this index person can infect more people compared to the original vaccine virus that can affect less people here. Right. So, again, all these vaccine, right, basically show that there's still a good efficacy of all these vaccine against all these mutants, or all these mutation, all these variant of concern. Yes, some variant, right, is a bit more stubborn, right? So the vaccine doesn't work very well, but still it's not a zero efficacy. So it still does help people the vaccine still does help protect people against other type of variant of concern as well. Our own guideline, now the own guideline also had this statement, okay, saying that, look, the commonality, right, is basically the Pfizer BioNTech vaccine, right, has got good efficacy against the mutation, but the guidelines also admit the Sinovac, right, still require more information for us to judge whether it's working, it works or not against all these variants of concern. Right, this is my last slide. Okay, so one of the reason I agreed to take up this talk is actually about this lah. I mean, vaccine, okay, it's not a magic bullet. We know that it's not a magic bullet. It cannot, we cannot guarantee, okay, that people who have been vaccinated will not get infection. We cannot guarantee nowadays. We cannot guarantee that 70-80% of population get vaccinated. We cannot guarantee herd immunity, right? So we start to recognize that. We stop talking about herd immunity, right? So, but there's a good evidence to tell us that, look, the vaccine works. The vaccine, right, okay, help to reduce the case, reduce the severity of the illness, and thereby less people suffer, less people die, and there's definitely will be less strain, okay, to our healthcare facility. Now, this picture I just snapshot today, right? So we have reached about 18.6%. Okay, so it's far from enough. So I'm here to encourage. Okay, we all here. Now I'm sure that a majority of us here are eagerly waiting for your turn to get vaccinated. I also know, right? A small proportion of us, right, will not be swayed by evidence. So basically, it's you are not interested in vaccine, right? But I think there's also a lot of people who are standing on the fence, right? I know people who are standing on the fence. So I'm here to encourage these people. Hey, look, okay, go and queue, go and register yourself in the MySejahtera, wait for your turn, and when it's your turn, right, go for the vaccine, right? We need every single of you to get a vaccine, to have some hope, okay, for this pandemic, for this country, and for our healthcare system. Okay, with that, I thank you for your time.
Thank you very much, Dr. Chua, for that very informative, interesting look. Actually, giving case histories are very good because it gives us a real life look at what actually happens when patients actually come and see a respiratory physician. A lot of questions have come up, but a lot of questions are ivermectin. Everybody is thinking is a conspiracy. We don't want to say anything about it. So could you discuss some of that with the public?
Personal opinion. There's nothing to discuss. Right. Look, medicine, right? Okay, we talk about evidence-based medicine. Whatever we do, okay, whatever treatment we give, right, it must be proven, okay, with scientific data, scientific study, right? At the moment, right, there's not enough data, okay, to support the use of ivermectin. I'm sure a lot of you, right, get a lot of information on the internet, say, oh, it's super wonder, it works in India very well, and there's conspiracy theory about, oh, because it's a generic drug, there's no interest in it. I assure you that is not the case, right? Ministry of Health is doing study. Okay, I'm aware that HUKM, right, is doing a study on this, right? We need evidence. We need good scientific evidence before we apply, before we give it to our patient as a clinician, right? So now for those people who like to go on and argue about this, right, let me remind you of one word. The word starts with H, is hydroxychloroquine, right? So now, I'm sure 1 year ago, a lot of us heard about this, hydroxychloroquine, the anti-malaria drug that works like wonder. Yeah, okay, so at one point, the India had to stop the export of the medication. And look at where we are now. Anyone talking about hydroxychloroquine? None, actually. Because as time goes on, as the evidence starts to come in, right, we realize that it doesn't work. right? So ivermectin at this stage is the same like hydroxychloroquine 1 year ago, right? I do not deny that maybe later on we will have good evidence come in and say it works for the milder group of COVID. Yes, I don't deny that, but I think as per now, as per today, I will say there's no evidence that it works. Okay, so we have to stick to evidence-based medicine, and it's really beyond. It's not supposed to be in our day-to-day practice of how we help people to recover from COVID.
Okay, thank you, Dr. Chua. We've still got a lot of exciting things to go through in this particular seminar. I'm gonna take a break for 2 minutes to have an alpha video, and then we'll come back to you with the testimony of 2 patients, as then we'll also take all the questions. Okay, let's have the alpha video.
Life moves fast, doesn't it? Every day there's so much to fit in, but do you ever stop and think, what's the point of it all? Do you ever ask yourself, is there more to life than this? Alpha is a series of sessions exploring life, faith, and meaning. It's a space where you can ask all the big questions, say what you think, and hear about other people's points of view. First, there's video and then discussion. Each video explores a different aspect of the Christian faith, and then in a small group, you get to say exactly what you think. The aim of each video is to spark conversation, each week unpacking a different question. It's an opportunity for you to hear from others and contribute your own perspective in an honest, open, and friendly environment. So why not try it out?
My friend introduced me to Alpha.
I learned about Alpha from my wife, a restaurant owner, which my parents and I have a dinner there, and she's actually kind enough to share the details of the Alpha with us.
When you have question, you can go to Alpha because there a lot of people will come. When you put forth your question, they will clarify your answer. See the same thing in different manner and from different perspective you can see.
I benefited from the Alpha course through growing spiritually and sharing my ideas with other people and basically meeting so many other people.
I'm able to stand up from falling into depression, as I've lost my son not too long ago.
What I learned when I joined Alpha is to ask questions, which can be difficult, even for people like me who's grown up in church, but in a safe environment where you can discuss things that you're not sure about or work through your doubts.
Nice game, nice people, so I had a lot of fun also.
Okay, so welcome back to our program. We're gonna have a short conversation from 2 of our friends, Corinne and Vincent, who actually gone through COVID-19, because the topic today is inside COVID-19. We've heard from the doctors who treat patients inside COVID-19, inside the private hospitals, whether in the ward or in the ICU. Now we're gonna hear from 2 people who have actually gone through this. So we're gonna introduce Vincent Yee, who actually had COVID-19 and wound up in Sungai Buloh. Vincent, welcome. Tell us about your experience. Unmute, please. Unmute. Okay.
Okay. Thank you, doctor. Okay. I was admitted to Sungai Buloh Hospital on the 6th of May, 11 p.m. after a long hour of calling. So I was in the COVID-19 ward. The floor was full of people. They were coughing and coughing and coughing, and I heard some groaning too. I do not have cough. I do not have sore throat. I do not have fever, and I got only a running short of breath. But putting me in such a frightening situation, it was very frightening. It was scary, you know. I thought my time was near. I cried out to God. I said, God, pull me out of here. I don't want to die. I don't want to end my journey here. I cried out to God. And at that moment when Pastor Lin called me, just imagine, I answer him, I answer him like a small boy, you know. I said that, Pastor, 我好驚啊. What do you mean by 我好驚啊? So that reminds me of my daughter, 35 years ago, during the middle of the night, he ran to my room. And then he talked to me, Daddy, 我好驚啊. I said, what happened? And my daughter told me that devil is catching me. Devil was chasing me. I said, don't worry. Come, sleep with Daddy. My daughter jumped into my bed. Within 5 minutes, he can sleep deeply, he can sleep calmly, he can sleep peacefully. Why? Sensing of security, sensing of assurance from the father, from my father. Yes, my daughter was sleeping in the arms of her father. And after the prayer, after the prayer together with my pastor, and after reading the scripture, I was able to sleep peacefully, calmly. Why? Because I was sleeping in the arm of my Heavenly Father. Thank you, Lord. Thank you, Lord.
Okay. Thank you.
Yeah.
Thank you. All right. How long did you stay?
I stayed there for about 7 days. 7 days.
Okay. And you got no more symptoms after that?
After that, yes. I was only running short of breath. So doctor and nurses try me 3-4 times. You know, after taking out my oxygen, my level is very low. So he got to put it on again, you know. After 3-4 times only, then I'm okay. After 3-4 times, then my level of oxygen is above 95. Okay.
Are you vaccinated now, Vincent?
No. In fact, I called the Sungai Buloh Hospital. He said that come on the 14th of July to check first for the checkup. Yeah, after 3 months.
All right, good. Okay, so we are running short of time, so we need to cut things a bit short. So let's have Corinne, who's actually been admitted to Subang Medical Center ICU under the care of doctors like Suresh there. Welcome, Corinne. Thank you for joining us online. Can you share with us a little bit of your experience?
Yeah. I was tested positive on Sunday. Okay. And I monitor myself, and I didn't report to the government. I didn't go to CDC to do an assessment because I was worried that that they might send me to a government quarantine center, which is I was told is packed like sardines. You know, I didn't want to go through that. So I monitor myself at home for like 1 week. You know. Initially, I just have a sore throat. Okay, I keep drinking a lot of water. Keep drinking this ginger with lemon, honey drink. I keep drinking. It didn't go away. And then from the 3rd day, 4th day onwards, I started to have fever already. And I consulted our GP, Dr. B is also our church member. I talked to him. Even on Labor Day, 1st of May, yeah, I remember 1st of May, Labor Day, he was kind enough to open up his clinic. He gave me a video call, he assessed me, and then he gave me some medication. But of course, I didn't go and collect. I get my sister to go and collect for me. And I've been taking it faithfully for, Saturday and Sunday. And then it didn't improve. I know I'm more serious than that, okay? And so come Monday morning, you see, from I tested positive on Sunday, and then now to Monday, more than a week already. I called Dr. Peter. I said, Dr. Peter, I need to, check into SGNC because I'm having difficulty in breathing already. Okay, I know everywhere, every hospital, they're all packed. You see, that's why I called Dr. Peter, and Dr. Peter said, "Okay, give me a few minutes." And then after a few minutes, he called me back. He said, "Okay, you can. There's a ICU bed waiting for you, reserved for you. You just come in." Okay, and I went in, and the doctor checked. I was at the emergency like for 2 hours plus before they admitted me. And Dr. Ronald came and see me, assessed me, and he said I need to be put on an oxygen mask, okay? And he said I need steroids, and he gave it to me. Steroid, beside that is, and a lot of other things, few other medication, he gave it to me. And I was there like for a couple of days. And then Dr. Ronald told me, your case is not so serious. He said, we put you into a ward because there are more serious patients that need the ICU. So, okay. You see, the ICU is a terrible place to be in, okay? There's no day and night, because they have the lights on throughout. So you can't tell whether it's day or night. So, and I cannot sleep. And when nature called, and that was the worst thing. You cannot get out of the bed. They will bring you the bedpan, okay, to do your business. And when they told me, when Dr. Ronald told me that I can go into the ward, I was so happy because ward, there is toilet in there. So I was at the ward for like a couple of days or so. I continue with my treatment, yeah, oxygen mask, steroid, the kind of thing. And I didn't get any better, okay? Didn't get any better. In fact, it got worse. Like what Dr. Suresh said, I think maybe that time of stage 3 already. And every other day, they will come and take X-ray, they'll take my blood, going to check. And I didn't get any better, but I got worse. So Dr. Ronald said, I need to go back into the ICU. And back I go into the ICU again. Okay, and then Dr. Ronald said, look, you are not getting any better, so I'm going to give you the high dosage of steroid. It's going to cost like 6,000 to 7,000 a dose. And I only need one dose, luckily. Then I told him, yeah, please give it to me. I want to get better, I want to get out of here. And he gave it to me. I thought that's it, I was so naive. I said with the steroid in, the strong steroid in, I would just recover there and then. But actually, no, okay? In fact, it deteriorated. My health gone bad. And until the Dr. Ronald said I have to put on the, what did Dr. Suresh say, the high dosage of oxygen, it has mist, water, for the tube for the water to drain off. Yeah. And so they continue to monitor me, okay? And because I was not getting any better, the hospital called my son. I have 2 sons, okay? And my son immediately video called me. Both of them were crying. I said, why? Because they see, their mom with all the masks on, or the tubes here and there, and I'm not getting any better. They thought, they're going to lose me. Okay. I just cut them short because I need to, to rest. Cut them short. And for 2 nights, I was very drowsy. I'm not my usual self. I just cannot sleep. I dare not sleep, because of the mask, the oxygen mask. I'm so afraid that, the mask will come off, which it did at one time. Oh, it was really hell, let me tell you guys. And now thinking back, really scary, As a Christian, okay, I pray a lot. Okay, I pray a lot. I have my laptop with me. On my laptop, I put on the worship songs throughout. And during the darkest days, the last 2 days, I put in louder, okay, so I could hear properly. And then my Pastor Victor, keeps sending me Bible verses, and I put it on audio where I could hear. Okay. I pray, Lord. Please have mercy on me. Okay. I said, Lord, if you really want to take me home, you can take me home. My sons are. And that night, when in my drowsy state, I visualized Jesus. Okay. Jesus was sitting on a big rock facing the sea. He waved to me, and I went to him. I sat down with him, with my back facing him. I also was facing the sea. Jesus told me, "Child, don't worry, you'll be all right." Okay. I had this vision twice, 2 nights in a row. I mean, I don't even know whether it's at night or not, because, I just dare not sleep. I was so scared, so terrified that the mask would come off. And with all the noise, in the ICU, the machine beep, beep here, beep, beep there, the nurses keep walking in and out. And unfortunately, next day to me was an old uncle crying, asking for Yong Tau Fu. I remember he was screaming away for 2 nights, and then after that there was no sound from him, all quiet, and I heard the nurses and the doctor rushing to him. I don't know whether Dr. Suresh was there or not then. All these things terrified me. Until today, okay. And
so how are you today, Corinne? How are you today, Corinne?
I still have this long COVID symptom, but it's getting better. Okay, I still get a fever on and off, not very high, but around 37.2 thereabout. And every time when I have fever, I don't feel good. You see, I need to rest. Yeah.
Are you breathless?
On and off. If I were to walk more, you see, I do get breathless. Yeah.
Okay. All right.
The worst is I cannot sleep at night.
Okay, good. I think you have got long COVID symptoms. Well, anyway, thank you so much for your testimony. It's been very enlightening. It's not a good thing to wind up in ICU. We're going to open this time to questions to our expert panel, Dr. Suresh and Dr. Chua. A lot of questions have to do with therapeutics, so maybe it will be Dr. Chua who has to answer a lot of these questions. So the first question that comes out, we've got about quite a number of questions that come to us before the seminar actually began. Some of you have written in. We've got about 59 questions, but I want to choose the most pertinent ones. If you've got long COVID, like for example, Corinne has, obviously, what can she do to improve her lung function?
Right.
Dr. Chua?
Number one, be patient. Be patient. So this recovery takes time, right? So as time goes on, the body tends to heal itself further. That's number one. Number two is, sometimes you may consider a rehabilitation program. SGMC do have this. It's run by the rehabilitation physician. Recognizing the need of all these post-long COVID syndrome, right? Actually, sometimes a rehabilitation team can help. So there's another option. Sometimes, again, you can say extrapolation of data. You know, some people after a viral infection, right? I mean, sometimes some supplement helps a bit, right? So, but another thing that I think Corinne was saying is a bit of fever here and there. I think 37.2 is not too bad, lah. I think if it's a bit higher, if it touches 38, right, then be careful. You know? Obviously, it can be a long COVID syndrome. It can be just fever without infection, but sometimes you don't know. It can be some infection going on in the background. So better go back to consult the doctor and say that, look, I got this fever. Do I need to worry about it? Do I need antibiotic? If the doctor check, say no issue, then it's your long COVID, then you just be patient.
Yeah, okay. Her face looks kind of rounded. Do you think that's an effect of the steroids, Suresh, you think?
Suresh, you're muted.
Suresh, you're muted.
Okay. I don't think so. I think he hasn't had really Cushing-oid appearance yet. I mean, together with the facial puffiness, there should be skin thinning, easy bleeding, easy bruising, and all that. So it's possibly just a normal look.
Okay. Now, the thing that's come up about vaccinations nowadays is about this mix and match, having AstraZeneca first, as then followed by Pfizer or mRNA vaccines. In fact, Angela Merkel's government just came out to say that they were in favor of that. So any of you two have any comments on that?
Personally, I would just say wait for evidence. I mean, yes, I agree. There's some evidence to come and say that mix and match works better. It induces more antibody reaction, okay, and gives us more coverage. Yes, I agree to that. But again, I'm just that type. I'm the type that I'll wait for guideline. I'll wait for guideline to tell me that, look, we can do this, and then we'll do. I do agree there's early evidence of such.
Okay, all right. So another question that came over YouTube was, you know, the person who went to hospital and they got their own supply of ivermectin and they want to take it. Do they have the right to take their own ivermectin, or are there any side effects of ivermectin?
Suresh, would you allow that in your ICU?
I wouldn't.
Because you're not allowed. So there's implication of this. Look, I mean, we know some patients sometimes take medication behind our back. Right. So, but this is a serious illness. I think there's implication of it. Okay. Now, look, number one, the medication itself, right? So, to be honest, I admit I never used this drug before. You know, it's a vet drug, right? I mean, it's not meant for humans. So, what's the side effect? If I use it for my patient, right? What's the dose and what's the side effect I need to expect? What's the side effect I need to watch out? I have no idea. So, if someone take it behind my back and when something happened, I say, and I don't know about it, assume I don't know about it. I say, hey, why is this so odd? You know, why is this COVID patient moving along the wrong track and something else is happening? Maybe the liver is failing. Maybe the kidney is failing. Why is it happening? I don't know. So be careful. The next thing is because of interaction, medication interaction. Because once you take one medication, let's say ivermectin, and I have to give you favipiravir or steroid, these two medications, they may have interaction, right? So then it may create problems. So no, that's not allowed.
Okay. Dr. Chua, the interesting question that came out is that, look, if a patient has had COVID-19, wound up in ICU, got discharged, right? It got pulmonary fibrosis as a result. Can that person ever go back to a normal lung function, or is that person damaged forever and ever?
It depends, okay? Now, I've seen patients who fully recovered, okay? Stage 4, I think it was a stage 4 patient, fully recovered, yes. But I've also seen someone, like I mentioned, I think it was my case 5. I mean, I did a scan, right? I think about 2 weeks ago. I look at it and say, no, this lung cannot recover. Even if he get extubated, even if he move out of the ventilator, right, he will not be able to function normally. So that's why there's some case report from China that some post-COVID patient end up with lung transplantation. That's actually because, right, the patient just couldn't recover. The lung is just permanently damaged. So they end up with a lung transplantation. So some people recover, some people don't. Okay, so only time can tell. But sometimes the CT scan appearance gives us some idea as well how much they can recover.
Okay.
So I would say case by case.
Okay, Dr. Suresh, do we have to vaccinate every year? How long can the vaccine last?
Well, it is supposed to be at minimum 6 months, but the data, there are some discussions going on whether you need a third booster or you need a yearly vaccine. No one will know until we have a large portion of the world population vaccinated and how this virus pans out. So at the moment, no, we don't need further vaccination, especially if we have a significant number of the population vaccinated, and that's the goal.
Yeah, a couple of myths have come out. Number one, Dr. Chua, is our immunity lower after vaccination for at least 2 weeks? This is a common thing that people tend to ask. You see, they think that if you get vaccinated for the first 2 weeks, you will actually have a lower immunity because you got higher incidence of COVID. What do you think?
No, I mean there's no evidence of such, and this will go against the principle of vaccination. I mean, all this while we know we have our vaccine, our hepatitis B vaccine, our influenza vaccine, pneumococcal vaccine, meningococcal vaccine. No, there's no evidence that following a vaccine the immune system will drop. And if we understand the how the vaccine works, right, there's no reason that the COVID vaccine will interfere with the immune system.
Okay. Okay. What about to either of you to answer this? There's again something has come up recently. Questions have all come up to us in this seminar. One of the side effects of AZ is blurred vision. Is that true? Would you get blurred vision or visual side effects?
Well, I mean, I would say the host of complications or side effects, but the serious ones with AZ has been the very rare incidence of thrombosis. I mean, blurred vision could be a symptom of something which is happening in the brain, could be happening anywhere else, but I don't think I've heard of significant number of complaints about blurred vision.
Dr. Chua?
Oh yeah, definitely. I mean,
blurred vision?
I would say no, that there's not a commonly listed side effect from the AZ vaccine. I don't deny this is maybe related to the vaccine itself. I don't deny that, but I would say that this kind of case, because it's so uncommon, right? It has to go by case basis. If this kind of thing happen, assess by ophthalmologists, right? See what's going on with it. So sometimes maybe this is not relevant to the vaccine. I mean, I'll say it's still possible, but it's going to be very rare, very rare indeed.
All right. Now another AZ one. This is they're worried about, they've been vaccinated with the first dose of AZ. They're worried about the second dose getting more reaction or blood clots. So they want to ask whether they can skip the second injection. Is the second injection more dangerous than the first injection?
No.
In terms of side effects.
Right. I mean, true. I mean, I think a lot of us who have been vaccinated would agree that after a second dose, I mean, I don't think it's just AZ. I mean, just all the brands. I think after a second dose, right, there tend to be small side effects. Okay, but again, those are manageable. So it's not something that we need to worry about, and it's definitely not something that's worth skipping the second dose for. Now, you want to skip the second dose, of course, we cannot stop you, right? So, but you must understand that by just doing the first dose, right, okay, the protective effect, right, will be not optimal, will be suboptimal compared to if you get two doses.
Okay, right. So there are some questions on the Slido. Sweatway, can you put it up? Sweatway, can you put up the questions on the Slido, please? Okay, let's go to some of these questions from the people who are already here. Are we able to differentiate between COVID-19 positive infections and those non-infectious? Question by Tony. Suresh, can you answer that one?
Well, yeah. So it's a combination of constitutional symptoms like fever, influenza-like symptoms, and a positive PCR test. Now, sometimes patients who have recovered from a COVID infection would have a positive COVID test even 3 months later. And this is because of shedding of the dead virus. Now, there are certain ways where you can say this is not infection anymore. There's a thing called the CT value, which is high, would mean that, let's say, a value of more than 20 would mean that the person is non-infectious and not a reinfection. Of course, you have to pair it up with clinical symptoms like no fever, no flu, no body ache, and all that. Now, serology test also has been done to show, but not conclusively to prove that this is not reinfection. So generally in this hospital, someone who's had a COVID infection in the last 3 months, we generally do not repeat a COVID test because there's a possibility that they may still be COVID positive on the PCR, which is the nasal and oral pharyngeal swab. And if we do one, then we check the CT level, which is done in the labs nowadays.
Okay, so in that case, the next question was, patient was cleared stage 3 and 4 and they return home. What about their family? Can they mix with them?
No issue. Okay, by the time a patient is allowed home by your physician in charge, doctor in charge, right? That means that we are confident that this person is not contagious anymore. So they are allowed home. So and also from all the previous studies we know, I mean the active viral shedding, right? Actually most of them stop before day 7. So by the time of day 10 or even later than that, when they're released home, so they will not be contagious anymore. A lot of my patients ask me this question. So in general, I tell them that, no, I let you go home means that I'm confident you're not contagious. Okay, so you can just live like normal, just like before your COVID time, right? So for some patients who go home a bit earlier, like day 10, so I say, okay, if you're really worried, now you give yourself another 4 more days. You do 4 more days in your room isolation, then definitely there's more than enough for you to make sure you don't pass on this infection to the rest of your family.
Yeah, okay. So another question is that those who recovered from COVID-19 are supposed to be antibodies to combat the virus. Why do they need vaccination? That's a reasonable question.
Yeah.
By Tay Mealing.
Yeah, because we don't know how long the antibody will last. Right, so in general, by principle, the immunity, the neutralizing antibody lasts longer if it's induced by vaccine compared to a natural infection, right? So I mean, so because the natural infection, we don't know how long it lasts. So usually we say after 90 days, then these patients still have to go for their COVID vaccine.
Okay. What about
more prolonged immunity?
Okay, what about therapeutics? Somebody mentioned here acyclovir or ribavirin. Are they useful?
If you're talking about antiviral, right, the only thing that's available in Malaysia is favipiravir, right? So, but obviously, in some other country, then there's a remdesivir. That's also useful. But acyclovir and ribavirin, no, it doesn't work against COVID.
Okay. Question for Dr. Suresh from Peter Tan using YouTube. Is the side effects of AZ vaccine overblown? It's been heavily popularized. There's the side effects, you know, to give the impression that other brands have no side effects at all.
Oh yes, definitely. AZ is definitely a good vaccine. Very reasonable protection, and it's used quite widely in Australia and UK. And but of course, there's a small risk of thrombosis. The risk is actually very small, and the benefits of AZ over the risk is proven. So it's
okay.
It's a go for me.
Yeah, it's just overblown, isn't it? Right? Okay. Yeah. Dr. Chua, does long COVID effects apply to all categories, whether it's 1, 2, 3, 4? Are you more likely to get long COVID with stage 4 or 5 compared to stage 1 and 2?
Definitely. I mean, the more severe the original infection is, then the more severe the long COVID syndrome is, right? So and the more lower grade, like asymptomatic carrier, right? Usually they didn't have any problem during infection. They usually have no problem after the infection, right? So is a stage 2 patient.
Yeah. So Dr. Chua, what is the usual time frame for a person to fully recover from long COVID? Is there a time frame?
No, there's no single answer to that. Again, the more severe the infection is, the longer you take to recover from it. And I must admit, some patient, right, may not have a full recovery. It may not be achievable because of the damage done by the virus.
Okay. Now, for the audience, a lot of your questions sent before to us is about what are the conditions which you need to have before you can get vaccinated. I think Dr. Chua has fully elucidated all of that in his presentation, so there's no point going through all those questions. So you'll forgive me if I don't bring them up. Okay, you can always look back in the video, which is in Facebook or YouTube, to look at his slides, and you will get an answer for that. I will just take the relevant ones. Some people have testified that they recovered very fast after taking Lian Hua Qing Wen capsules. What do you think, Dr. Chua?
No comment. Not my medication. No comment. I've seen that. I've seen my patient taking.
You've seen that.
I have no idea what it is. I have no idea how it works. I don't know how well it works. But again, or for milder group of patients, because I don't give much treatment, then fine, you want to take it, that's fine. But for those patients who I put them on favipiravir, I put them on a steroid, and you take this kind of medication, I'll be worried in terms of what all these medication do inside one body.
Okay, so all right. The other question is that if I'm going to go for AZ, since got blood clot, should I prophylactically take aspirin?
No. Okay. No. I mean that wouldn't be necessary. I mean, again, all this is out in the guideline. I mean, you say about aspirin. Let me give you another example. Oral contraception, actually a pill. Sorry, the pill. So actually also increase the risk of for blood clot formation. So some people say, hey, I need to stop the oral contraceptive pill before I take the vaccine. The guidelines say no need. No need, just continue to take the pill and go for the vaccine.
Oh, okay, good. All right. Well, is the new Dr. Suresh, is the new Delta variant more infectious or contagious than other variants? Is it more deadly? And will the current vaccines suppress this new variant?
Definitely, the case reports coming from New Delhi in India shows that this is much more infectious and spreads faster. The Pfizer, I mean, all the vaccines gives you a protection against the COVID virus, even with mutation, because the genetic code is maintained. Now, the idea was never to get too sick. And I think the data is out there. Countries that have completed vaccination, even with variants involved, have shown that the death rate from vaccination has plummeted. So I would say that it would confer enough advantage. Even if you're infected, you won't become very sick.
Okay, right. Now this thing has come up because of this Taiwan debacle. A lot of people there have died after the AstraZeneca donated to Japan. So can any of Dr. Chua, what do you think? Is it a real thing, AstraZeneca causing death in Taiwan? The batch sent by Japan.
The first thing I want to say is, where's the source? Please verify the source of this information. Right. Personally, I to be honest, I haven't heard of this. Personally, I don't think this is going to be true. Right. That if 200 people die from a vaccine in Taiwan due to the vaccine, I don't deny that along the way, right? We have seen this. People get a vaccine, and then after that, they were driving, they had a heart attack, and they died in an accident. So this kind of thing happened. So, but the death, a death following a vaccine doesn't mean it's a death due to the vaccine, right? So I think number one, I seriously doubt the reliability of this news of 200 people died. But if they do, I would like to see the post-mortem and things like that to try to establish the cause of their death. I highly doubt that it's due to the vaccine.
Yeah. So in the same vein, governments have been swapping and changing. When it first started out, AZ was supposed to be given 1 month or 1 week or 3 weeks, 3 weeks or 4 weeks after the first dose. Then in UK, they stretched it to 3 months because they thought, they don't have enough dose. Question is, our government here says they will shorten it to 9 weeks instead of 12 weeks. Dr. Chua, what is your comment? Because these things change. Which is optimal for us?
Right. Wow. With this, I like to quote this Malaysian Medical Coalition. I think it's a combination of 12 or 15 Malaysian medical bodies. They will release a statement on this thing. one of the appeal, one of the suggestion, comment we make to the Ministry of Health or to the vaccine organization is that, look, we advise that we prolong the interval of the 2 jab, okay, right, so that we can give the jab to more people, right? So yes, I'm aware that the appointment, the AZ appointment have been shortened, have been expedited, so it's earlier. So why that is so, honestly speaking, I don't know, right? I don't know. But my stance will follow this Malaysian Medical Coalition. We say, look, we should prolong the interval so that more people can get a jab, rather than the same people getting 2 jabs. So that we can increase, we can broaden the coverage of the vaccine.
Okay, all right, good. So time is caught up with us. We're like 5 to 10 minutes past 4. One last question I put out is for Dr. Suresh. What is the benefit of the prone position in patients with COVID? What's the benefit? Why?
Well, it has been shown that prone position has been discovered when we were managing patients with ARDS or severe respiratory distress syndromes, where prone position has been shown to improve oxygenation in those patients who are refractory to high ventilator settings or high oxygen requirements. Now, how it helps is that when we are prone, the blood flow goes to the anterior part or the front part of the lungs, which is now dependent and which seems to be less affected by the infection, and therefore improving oxygen delivery. Now, with less amount of oxygen, now oxygen itself is toxic. High concentrations of oxygen is also toxic to normal lungs. So when we can reduce the amount of oxygen given through the ventilator, that will reduce the vicious cycle of damage to the lungs, and has been shown even in COVID cases and in ARDS to show to improve outcomes, lessen the mortality or morbidity.
Okay, I think the time has caught up with us. So just to remember all of you that the opinions expressed during this session are solely those of the presenters and not of First Baptist Church. So next slide, I would just like to take this opportunity to really thank Dr. Chua Ken Tiong, Dr. Suresh, Ms. Corinne Ao, Mr. Vincent Yee, all of you have spent time with us. We thank you so much for sharing. Now we understand what it's like to have COVID-19 illness and how to have it treated. Thank you so much. Special thanks to Olive Tree, whose sponsorship made all this program possible. Next slide, please. Just remember to join us at Facebook, FBC Community Connection. We're going to have lots of other programs coming up, by which, next slide, we're going to have the next one we're going to have on the 1st of August. So for all the consequences of COVID-19, people have to study at home. And this is targeted for parents and people learning. So we're going to have 3 great speakers on Sunday, not Saturday, 1st of August at 2 p.m. We've got Dr. Goh Chi Leong, who's basically a PhD in psychologist, Group CEO of Prestigian Education, in charge of Sri KDU, Rail Kids, Rail Schools. All right, so he will be a great speaker talking on the stresses of online learning, how you're going to make this a good experience. The other speaker is also a PhD in counseling psychology, Dr. Gerard Lewis, who is the CEO of Help Education. And last is Dr. Vincent Chen, who's a medical doctor who decided to go into education field. He's a principal of Fairview International School at the forefront of online learning. So if you want to know how to get your best out of online,
Okay. Okay, Suresh, I think we can leave already.
Yeah, I can't hear very well.
Thank you. Thank you, doctors.
Thank you.
Well, you're welcome.
I understand that Dr. Peter